the pictures of the cesarean section. And that's a useful learning tool to the extent that you're going to find, for example, and perhaps some of you know of examples of this, that women often report numbness, a period of numbness in the lower abdominal region, the perineal region, following that cesarean section. It's called a Phanestoel incision. And that's often because the nerves are transected in that region. There are critical arteries down there. So what I'm suggesting here, as you think about the images that we saw before, what could be done anatomically to avert that type of numbness, that type of problem? What are the nerves down there that would cause or be the cause of the numbness? Anybody recall? What are the nerves that innervate in both males and females the lower perineal wall? No, the pudendal is on the other side, and we're going to be talking a lot about the pudendal today, but in the anterior abdominal wall, remember, it was the iliohypogastric and the ilioinguinal. And oftentimes in that Phanestoel incision, those nerves are transected, and they really don't need to be. I think, again, if you're very aware of the anatomy, that can be minimized to a large extent. And then with respect to blood flow, there can be regions of ischemia, localized ischemia. A lot of this is compensatory. But what is the major vessel that you need to be concerned with in that type of incision? Anybody recall? I think I heard you say it. Huh? Well, no, the iliac, it's a branch of the iliac. It's the only really major branch of the iliac that we talked about. Remember the epigastrics. You have two epigastrics. You have the inferior epigastric that, remember, went up from the anterior rectus region into the rectus sheath. So remember the inferior epigastric branches out down there, but it goes into that arcuate line and into the rectus sheath. And then there are a series of vessels on the outside of the external oblique, or actually outside the anterior rectus sheath. What were they? We had an image of those. Those are the superficial epigastrics. So you have two epigastrics. You have the superficial on the outside, and you have the inferior on the inside that we saw anastomosis with the thoracic arteries and superior. But my point is, a lot of the damage, a lot of the problems can be averted simply by paying attention to the anatomy. I mentioned previously that a lot of this is organized around organ structures, organ systems, and I think we can simplify a lot of this just by making a few generalizations. So in the remainder of this unit and in the next unit, I'm just going to sort of zip through rather rapidly and just point out a few modifications to the general simplifications or general principles that we can adduce. So what we're looking at here is basically the blood supply to the female reproductive tissue. It really supplies to the upper urogenital tissues in general. And what you'll notice here, there are really three sources of blood supply to this region, three sources of blood supply. There are the gonadal arteries, both in male and female, the testicular artery and the ovarian artery. And notice it comes directly off the aorta, right below the renal arteries there. This testicular artery arises, tends to follow the ureter for a while, goes its own way. And so these dedicated arteries are specifically for the gonads. Then, remember, you can see here, there is a whole network of vessels. We had a picture of it previously, and I think there's another one coming up. A whole network of vessels that sprout the internal iliac, depending upon how you count these. Most medical texts argue that there are 9 branches. I'm not going to ask you to memorize the 9 branches because in virtually all cases, each branch is named for the structure that it perfuses. The umbilical artery, the uterine artery, the vesical artery. All right, so there's no great need to memorize those if you know that they all originate from the internal iliac. And then finally, I don't guess it's shown here. Yes, here it is. Um, this is going to be in the perineal region, in the most superficial region of the pelvic pelvis, the pudendal artery. And so a lot of our structures today are going to be perfused by branches of the pudendal. So it's really just these three major arteries that are going to keep cropping up over and over again for the remainder of our discussion. The gonadal artery, the branches of the internal iliac, and these are quite complex and profuse. And then we're going to spend a lot of time talking about the structures that pass through the pudendal canal. Venous drainage follows the arteries, except in virtually all cases, for whatever reason down here, the structure that is being drained is suffused or covered by venous plexuses. And you see these here. These are very elaborate, sophisticated plexuses. There's one up here that we'll talk about a little more later. But they all drain pretty much alongside the arteries, the related arteries. Don't think there's anything here you haven't seen. Just be aware of not only the relationship between the bladder, the uterus, the vagina, and the rectum, but be aware of the connective tissue. By the way, in the medical literature, a lot of times these recesses, these peritoneal recesses, are just called septa. So you know when you see a reference to the Douglas septa or the rectouterine or the rectovesical septa in the medical literature, what they're really talking about are these peritoneal invaginations between the tissues. And of course, we're looking at the female reproductive system. This slide is not particularly important, but I did want you to see the extent to which the female viscera are displaced by that parasite growing in the belly there. Look at how, for example, the stomach is altered, the intestines are altered, the entire region down here has a very different conformation. So it's quite remarkable. And you can imagine twins. I was going to put up a little animation today of two twins fighting each other in the womb. They have an MRI of that you can find on the internet quite easily. All right, so here we're looking at of course, the normal position. I have to be careful when I say normal. Normal position of the uterus and the vagina. You can see the relationship to the uterine tubes and the ovary. Be aware that this is the textbook position. This is the textbook image. It's a high degree of variability. Let's go to this image very quickly. So the terminology that's used to describe the position of the uterus is anti or retroversion. So if the uterus is flexed anteriorly, that's called anteversion. That's most common. Let's say 70 to 85%. If it's straight up, that's just called mid-position. And then about, 15% of the time, it'll actually be pointed backwards slightly. That would be retroversion. Now, the other thing that happens, or the other term that is used to describe the conformation of the uterus is flexure. So, regardless of whether the uterus is pointing forward or backward, sometimes it flexes forward, it bends forward, let's say a convex pointing upward in this particular illustration, or it bends the opposite direction. If it bends in this conformation with the terminus pointing down, that's called anteflexion. If it bends the other way, that's retroflexion. So again, don't confuse anteversion with anteflexion. Anteflexion just refers to the conformation or shape. But again, extreme variability, and when you looked at the image of the pregnancy, you can see how much that might be altered or distorted under those conditions. We've already talked about the layers, the laminar structure of the uterus, so you're familiar with the endometrium, which we talked about in the reproductive physiology unit, the myometrium, which is progressively displaced by the increasing vascularization and glandular over time. Excuse me as I forward the battery. And then the perimetrium is the connective tissue. I guess we would call that a sort of an adventitia because it actually is certainly more of a binding function to the abdominal wall. Now, every picture, every illustration, every rendering I have seen of these ligaments in this region of the peritoneum, peritoneal lining is a little bit inaccurate for a number of reasons. But what we're looking at here is, for the most part, the broad ligament. All of this is the broad ligament, and there are three components to that broad ligament that you should be familiar with. But in addition, notice the separation between the layers. So it's like a sheet. It's like a sheet draped over the uterine tube, at least a portion of the uterine tube, the proximal uterine tube. The position of the ovary is a little bit problematic. But it's useful to think of this separation continuing up to the point of the ovary. And that's going to be important because what do we not see here in this illustration? What is not shown? What's the distal end of the uterine tube? The fimbrium. And so there's going to be, again, this ovary and the fimbrium are going to be in a lot of different positions, but they're going to usually be fairly close to one another, and there has to be some patency, some access between at least the inferior surface of the ovary and the fimbrium.
Dr. King, can you just point out the three different tissues?
Yeah, we're going to get that in just a second. I have an illustration here showing that in just a moment. Before we do that, be sure that in an image like this cadaver image from the AP revealed, that you can recognize the uterus, you can recognize the uterine tube, the bladder is anterior here, and that you can recognize the peritoneal invaginations. So yeah, you have several illustrations of those three regions. Here we're looking at the entire broad ligament, and it's specialized. By the way, again, I think I've mentioned this before, but don't always assume that these structures are going to have this conformation. The right and the left sides are often very different, and they often have a dramatically different organization from individual to individual. So here are the three divisions here, the mesovarium, mesosalpinx, and the mesometrium. The region that folds over the uterine tube is the mesosalpinx, and that's what we're looking at here. Salpinx, we've encountered that before. Do you remember we encountered salpingian before in the pharynx? It just refers to tube. Just all salpinx just means a tube. And so the portion of the peritoneum that overlies that uterine tube is the mesosalpinx. I think you can pretty much figure out what the mesovarium is. That's the region that sort of drapes over the ovary. And most of the broad ligament, most of this is going to be the mesometrium. Now, there are several specialized regions of this broad ligament sort of acting in a suspensory or mechanical fashion. Here we can see the suspensory ligament of the ovary extending from the ovary. It normally extends posteriorly and superiorly, but that's not always the case. And you can sort of see the suspensory ligament running off this direction. And then there's a round ligament, which is more analogous to the spermatic cord of the male. It tends to usually follow more or less the same conformation. So mesoalpinx, mesoovarium on here, and then the mesometrium down here. So, by the way, as you look at that illustration, you should be able to name virtually all of the structures, even the ghosted structures. So we're looking at the pelvic diaphragm here. We're going to come back and talk a little bit more about this perineal membrane a little later. You can see the iliacus muscle there. So be able to sort of identify these structures in their relative anatomical relations. So the round ligament, we've indicated being the more anterior structure that sort of follows the trajectory of the spermatic cord in the male. Doesn't seem to have any particular function that we're aware of, probably vestigial. Be able to recognize the vesicouterine pouch, bladder, uterus, vesico-uterine pouch, just a enfolding of the peritoneum.
So much better.
The recto-uterine pouch, we see back here, all of this would be the rectal structure.
Douglas.
And all of this is showing, as I've indicated, what I've done, and I'm probably going to reorganize this at some other point in the future. But for each of these structures, there you have the innervation and the blood supply. So here we're just looking at the uterine artery. Thing to keep in mind here, the uterine artery is a branch of the internal iliac. It's one of perhaps 9 to a dozen branches, each of which in almost every case is named for the structure that it perfuses. Now, I don't know if you have this slide, or we posted these this morning, but it's not terribly important because, again, I'm not going to ask you to name all of the branches of the internal iliac, but you can see what a confusing morass we have here. I've heard anatomists on various lectures argue that the most complex region of the body is the hand, and I just don't agree. I think this region is infinitely more complex, not only because of the profusion of arteries and venous plexuses. By the way, they're not. Another reason it's not very productive, not very useful to have you sit down with an illustration and memorize these is because they're not going to look the same in 2 different individuals, and they may not even look the same on one side of the individual's body versus the other. So, but in any case, if you find it useful, this is the traditional mnemonic used, or not so much a mnemonic, but organizational scheme used to memorize the branches of the internal iliac. You can see the common up here, the external iliac, of course, that main branch that we talked about before is the inferior epigastric, which we mentioned earlier. And then all of this, there's what's sometimes called a visceral and parietal branch, a division of the internal that gives rise to all the other vessels. And this all happens, that division between the external and internal occurs at about the same level as the sacrum. What am I trying to say? Well, the lumbar vertebra transition to the sacral vertebra. Now we're going to talk a lot about the innervation as we continue, but remember the general scheme that we talked about before. We have a superior hypogastric plexus, we have an inferior hypogastric plexus. Everybody see that? So this in general is going to be our superior hypogastric plexus. And all of these illustrations, this is the inferior down here. And they're joined by this hypogastric nerve or nerves here. All right, so that's the general scheme. But notice the following. We can talk about this now. We won't have to worry about it later. Notice that the gonads, this is true for the testes and the ovaries, are innervated by a periarterial plexus that comes directly off of the aortic plexus. So while there's branching, interconnections between these plexuses and the innervation of the gonads, most of it comes directly off the aortic plexus and is dedicated to true for the aorta, true for the ovary and true for the testes. Now again, all of these illustrations are a little troubling in one way or another, but let me just point out a few things here that are worth generalization. So here they're summarizing the superior hypogastric plexus here, and what they're calling the pelvic plexus here is more or less the inferior hypogastric plexus. But what I want you to pay attention to is notice our color scheme here. So the blue is what? Sympathetic. Do you see any pattern between the blue and the red? Any pattern between the sympathetic and the parasympathetic here? Because this is going to come up again in just a moment. Notice that the uterus is predominantly innervated by what division? Sympathetic. All right, so this inferior region, and you have to be careful how I say this, but the inferior region of the pelvic cavity before we get into the perineum, get below the perineal membrane, that's mostly sympathetic. Then what is a little misleading down here, this pelvic plexus is mixed. Here they're showing it to be predominantly parasympathetic, but it's mixed. What is true is that most of this innervation, most of the superior innervation to the uterus is sympathetic. And again, we're going to see that as we get to the GI tract a little later as well. And then, as I say, there's a restoration of sanity when this is the pudendal is responsible for somatic innervation of the distal vagina, for example. Just showing you the derivation of these fibers from the lumbosacral plexus. But this one maybe is worth looking at a little bit. So here's the superior hypogastric plexus, sort of shown in sagittal section here. Here are the hypogastric nerve or nerves. And then all of this is the hypogastric, inferior hypogastric plexus. And so notice the following. Arising from that inferior hypogastric plexus, you're going to have a uterine plexus, for example. You're going to have a vesical plexus. So those terms are used to describe the tissues, as we talked about with the blood supply. But in most cases, they're just emanations of that inferior hypogastric plexus. Uterovaginal plexus, again, suggesting the same thing. So we talked about all of these structures in the reproductive unit. I don't think there's anything to talk about too much here. You can see the dedicated ovarian artery we talked about arising directly from the aorta. You know the regions of the cervix. We talked about the wall, the laminar organization of the uterine wall. We talked about how what we're looking at in this gray here is how the peritoneum wraps over the ligaments and the fallopian tube. Trouble again here, the most critical part they've kind of fudged out on, and it's not very clear what's going on here. But just remember, all of this peritoneal lining is sort of draped over those structures. As with the males, the female fallopian tubes can be separated or cleaved as a mechanism of birth control, tubal ligation. There are various ways to do this, and generally fairly effective, fairly irreversible. We talked about ectopic pregnancies. Again, this can occur most commonly in the uterine tube, but we've seen that it can occur in the ovary as well, and it can occur in other locations. The mechanics of that, how that all falls out, is sometimes difficult to appreciate, but the most common placement of an ectopic pregnancy is in the uterine tube. So these cadaver images can be somewhat difficult to parse sometimes. Of course, we're looking into the pelvic inlet here. We can see the relative position of the ovary, the fallopian tube, the uterus, and the rectum. Now, nothing new here. This is just reminding you that those gonadal arteries, in this case the ovarian artery, is descending directly from the aorta on down to the ovary. And notice in this particular illustration, its relative juxtaposition to the ureters. We've used the term pampiniform plexus in the past, but I hope you see that the pampiniform plexus, and you have it in the spermatic cord of the male and sort of covering the superior surface of the ovary. It's really just a specialization and just a regional modification of this extensive venous plexus that covers virtually the entire genitourinary system. By the way, the usual explanation, especially in the male, if any of you recall your basic biology or physiology, is countercurrent flow. Anybody remember that term, countercurrent flow? What was that all about? Exactly right. Remember, especially for the testes, this is a mechanism, all of this is a mechanism to regulate the temperature of the testes. And so the countercurrent flow, as the warm arterial blood is passing in one direction, and the cooler venous blood is wrapped around that artery, acts to equilibrate or maintain a consistent temperature. So I don't think there's anything new here. We actually looked at this illustration before. Again, be able to name these structures. And the only unique feature of the gonadal innervation is that for the most part it bypasses these hypogastric plexuses and comes directly off the aortic plexus. And it is a hybrid plexus. In some cases, we can talk about this later a little bit. In some cases, we know the function of these autonomic fibers. In some cases, the purpose isn't quite clear. All right, so that's all of that. Any questions there? If not, let's turn our attention to the last unit here. Everybody breathing a deep sigh of relief. Let's talk about the perineum. So the perineum isn't very precisely defined. It's pretty much everything below the pelvic diaphragm. So everything below the pelvic diaphragm, that layer of muscle and aponeurotic tissue, all the way down to the skin and the genitourinary openings, that's all considered perineum. Now we're looking at the pelvic outlet here from below, and traditionally the pelvic outlet is divided into two regions, two triangles. The dividing line there, the separating line, is the ischial tuberosity here. And anteriorly, there's the urogenital triangle, and posteriorly, the anal triangle. The terms more or less indicate the contents of each. And you have a couple of illustrations showing the relationship between the two. Again, the urogenital triangle is anterior, anal posterior. Now, this dividing line, this line here is rather important structurally because it's the site of this structure right here called the perineal body. You're going to have patients that have problems with the integrity of the pelvic diaphragm. And when that happens, it usually happens because there's an issue right here in this fibrous tissue, or because there's some type of congenital detachment peripherally with the perineal membrane. We'll come back to that in a moment. But this is a very, very critical structure here, just anterior to the anus. And one of the curious things about it, it is a densely fibrous tissue that contains both skeletal and smooth muscle. But once again, extremely important for the integrity of this region. It's not shown here. Not shown here, and it's very hard to picture this in most of the illustrations. But remember, this whole region in both the male and the female is called the urogenital hiatus, and it consists of an interleavening of muscle and aponeurosis. And so this sort of keeps it all bound together. In addition, and you have a couple of illustrations here, you can look back and forth between these two. So here's our perineal body, and then running or extending to either side of that is this transverse perineal muscle. Transverse perineal muscle, which serves as sort of a transition zone between the perineal membrane, which is this white region or light-colored region you see here, would be all of this in here. So the perineal membrane, and by the way, this terminology is as complex as the structures here. Perineal membrane sort of is unattached posteriorly, but extends all the way to the pubis, or almost all the way to the pubis. Usually there's a little opening right here to allow a neurovascular bundle to pass through, but otherwise it's attached all the way to the ischium all the way around. Now, do you remember in our sagittal sections, again, I didn't bring up a sagittal section here, but in our sagittal sections, when we looked at the perineal membrane before, it had a disc shape. It wasn't a clean linear membrane. It had a palpable thickness to it. Well, the perineal membrane in this illustration and in the preceding, is actually the inferior portion, the inferior surface of that disc. Of course, anatomically, the problem is that we're calling this inferior surface the perineal membrane, and in most medical texts, that entire disc. Remember, when we looked at the male anatomy before, we saw the blood on either side of that membrane. Well, in reality, it used to be called the urogenital diaphragm. That term is no longer used. To my knowledge, there's no term used to displace it. But what I want you to understand is that there is a space between this membrane and the pelvic diaphragm. This pelvic diaphragm continues all the way to the pubis, all the way back here. So you can imagine a tiny little space in here, and that's important. That space is important because in males, for example, it contains a portion of the urethral sphincter, and it contains some glands. You remember what glands are contained in that little region in here? Yeah, the bulbourethral or Cowper's glands. No, the female. So in other words, if we were looking at the male urogenital hiatus here, we wouldn't see the Cowper's glands because it'd be on the other side of the perineal membrane. But the female has a couple of analogous glands called the Bartholin's glands or the greater vestibular glands, and curiously, they are outside, I guess inferior is the proper term to use, superficial to the perineal membrane. Those are mucus glands. So all this back here is pelvic diaphragm, and while it's not shown, that continues all the way anteriorly. So be sure you can differentiate, for example, the perineal body, the transverse perineal muscle, the pelvic diaphragm back here. The levator ani is really what all this is. This is the portion of the anal sphincter we'll talk about later. Oops. And all of this in the female is basically erectile tissue. This is the crus of the clitoris here. There are the clitoral bulbs or the helicine bulbs here. And all of that is female erectile tissue for the most part. If we have time, we'll come back to that. So here we can see that transverse perineal muscle. We don't really see the perineal body in here. We can see this muscle that's labeled here, the bulbocavernosus. The proper term, the modern term, the more recent term is bulbospongiosus. And that muscle sort of is like a orbicularis muscle. In the female, it surrounds the vestibule, surrounds the labia minora. And then in the male, it sort of forms the inferior surface of the root of the penis. That's the bulbospongiosis. And then back here, we can see components of the external anal sphincter. Now, in this illustration, we can see the differences between the male and the female. You can see the levator ani over here on the left and there. There's no particular difference with respect to the pelvic diaphragm. The urogenital hiatus, of course, is going to be different, and that's going to be, as we pointed out, composed of both aponeurotic tissue and muscle. But now we have a problem up here, and I don't know quite what to tell you, except that if you'll notice, what we're looking at here is the urethral sphincter, both the male and the female. And as our general discussion has maintained, the female anatomy on this point is much more complicated than the male. And remember that we looked at this before, the female urethra is short, but it has concentric muscle. It has the smooth muscle anteriorly and then the skeletal muscle concentrically arranged around that. So that's what we're looking at here. In reality, the female external urethral sphincter has several parts, including this one. And that's the compressor urethra right here. It's not particularly important for our purposes, except that that's an accurately rendered illustration of the compressor urethra. trouble is, as far as I know, and one of you may want to explore this just out of the sheer initiative of proving me wrong, but I'm not aware of a compressor urethra in the male. This is incorrect, as far as I know. So that should not show that muscle extending over to the ischium from the external sphincter in the male. The male's fairly simple in more ways than one, as we all know. So is that clear? Just be aware that, I guess the way I would summarize this is the female sphincter, the female external urethral sphincter is more complexly configured. There are usually said to be three components to the female external sphincter, one of which is the compressor urethra. The male doesn't have that, as far as I know. The male sphincter is a little simpler. We've already looked at it. I think we'll look at it again momentarily. And be sure you know the components of the levator ani. We've already talked about these. There's also this interesting portion of the male and female anatomy called the ischioanal fossa, and this is just a fat-filled region or cavity anterior to the gluteus maximus. It's usually shown as being continuous with the subcutaneous fat, and there's a little passageway where those two regions of fat communicate, and then extends anteriorly even up to the pelvic diaphragm. And I don't know that there's any function attributed to this except to perhaps render this region more compliant with all the movement that is involved. All right, as I say, we can dramatically simplify the remaining slides by just focusing upon this structure right here. And that's the pudendal canal. So remember, we began by arguing that the blood supply to this region, the inferior pelvis and the perineum, is either going to be gonadal, provided by branches of the internal iliac, or for the remainder of our discussion, this one, the pudendal artery, which runs along the pudendal canal. We can see the pudendal canal sort of shown here as sort of an L-shaped structure. But notice the contents. Again, it really simplifies our lives at this point. The artery, the vein, the nerve, all run through that structure. And remember, the nerve in this case is no longer autonomic, it is a somatic nerve. So all of these branches, whenever you see these yellow structures, and we're looking at the perineum from below here, all of those branches are going to be branches of the pudendal nerve. They're all somatic, they're all providing tactile sensation and muscular innervation. And they're all, in virtually all cases, named for the structure at which they terminate. So for example, here's the pudendal back here is going to branch into the inferior rectal. We can see here, again, very logical. There's a perineal nerve extending anterior, a couple of branches. And then there's a dorsal nerve that extends in the female to the clitoris and the male into the penis, but they're all basically the same general organization. And there are several slides here, but all pretty much saying the same thing. So I just want you to be aware of the fact that all of these scrotal nerves, dorsal nerve of the penis or the clitoris, the perineal nerves, all of these are of the inferior rector, all branches of that pudendal nerve. And you can see that canal sort of runs along the margin of the ischium there. Sort of see it there too, running along the surface of the ischium. So in the male, again, by the way, this is the bulbospongiosis in the male here. Remember, in the female, it sort of surrounded the vulva, but here it doesn't go all the way around. It just forms the base there, this region. And then there's a tendinous raphe along the midline. But these arteries, again, I don't know what to tell you except that it's a very simple exercise to associate the end artery with the structure that's being innervated, that's being perfused. So we've made our way down along the along the GI tract here. We're down at the genitourinary openings in the perineum. Here's the rectum up here. There's an interesting muscle here that sort of coincides with the external anal sphincter. We'll talk more about that in both the physiology of this class. Called the puborectalis, and you can see the puborectalis is pulling the rectum in such a way that everything distal to it is called the anal canal. That little red block that you see, the red rectangle, is being enlarged down here as the anal canal. Now, we're going to come back to this in more detail in just a moment, but that anal canal, again the distal terminus of the rectum, contains this glandular system here. It contains a number of structures, but those are all mucus glands. The anal columns, the anal sinuses that you see there, you can see they have sort of a serrated appearance, like a scissor, like serrated scissors. This is called the pectinate line. We're going to come back to that in just a moment. By the way, anatomically, there are several pectinate lines. But these are mucus glands, but more importantly, for our purposes, it's an important division. It's an important dividing line. And we're going to see why it's an important dividing line later. For one reason, the epithelium changes here. We undo the Z line. What was the Z line? Remember the Z line? Yeah, where the esophagus
Connects the stomach.
blends in or becomes the stomach, and was abrupt epithelial change. Well, that's sort of reversed here. We'll come back to that in just a moment. But again, just want to make sure you understand that at this region called the pectinate line, we have these mucus secreting glands that tend to secrete more mucus as the anal canal is distended. And by the way, we can also see, we'll come back to this later, portions of the anal sphincter here, both the internal and external. In fact, before we take our break, let's just look at this very closely. So remember, how many layers of smooth muscle are there along the wall of the GI tract? How many layers of smooth muscle along the wall of the GI tract? Only in the stomach, usually two. And so what if you'll notice here, here are those two layers coming down, and they then converge to form what we're going to call the internal anal sphincter. You can sort of see it there very clearly. Right there. And that's smooth muscle. And then this is, for the most part, we have to be careful. I think the proper term is striated, but I'm going to say skeletal muscle. This is voluntary muscle. And then it's sort of, you have this complex region down here that's prone to hemorrhoids, quite frankly, because of the organization of the muscle. But here's the internal sphincter, and there's the external. All right, let's take a break, and we'll talk more about the anal canal.